infarction happened about 3-4 days back. Look at the regional wall motion normality, and the LV ejection fraction is 33%. And if you notice at the LV apex, you notice there is a mass which is a mixed ecogenicity linear filling the apex, and the usual thinking is that this is an left ventricular thrombus, laminated thrombus at the apical part. Now, if you see it carefully, that's a closer look. Again, you would think this is a thrombus with a mixed echogenicity and a layered manner. But it may not be true. Then what it is, just what I'm going to show you. Now, this is another similar kind of patient which we did about a year back, and then you see there is again an echogenic layered kind of a structure there. And the common thinking and dictum is that this is an laminated LV thrombus. This is what has been our classical teaching throughout. No, it is not. It is actually an intramyocardial dissection hematoma. Okay, is that so? Yes, I'll tell you how. Now, this is actually a subacute form of a cardiac rupture. It's a rare manifestation. It happens in about 0.4% of the myocardial infarction cases, and it's related to a reperfusion kind of an injury. The usual story is patient comes with acute myocardial infarction, you do an enzyme, you take the patient to the lab, and then with an ST elevation you see it, and you do a primary PCI, or in case the patient presents little late, you can give a thrombolytic therapy, and then you do an echo on a second, third day. That's the usual story. And once you do an echo, you might find something like this, what you've seen. So now, what are the sequence of events? How does this intramyocardial dissection hematoma develop? This develops because there is an acute ST elevation myocardial infarction. There is a reperfusion injury. This causes a bleeding inside the myocardium, causes the hematoma, and hematoma actually goes through the fiber separation, and this makes a linear kind of a hematoma in between the layers of the fibers, myocardial fibers. I'll show you the myocardial fibers in subsequent slides. And then you see what you see on a time frame. You see various forms of thrombi organization, fibrosis, liquefaction, like that. Now, this is a pathological specimen. I picked from one of the studies. You see there is this is an intramyocardial hematoma. That's how it looks like in acute myocardial infarction. I talked about layers of the myocardium. Yes. Then what are these layers of myocardium? This is an autopsy specimen of bovine, human, and porcine hearts, and you see this is a single layer of myocardial sheet which comes in a kind of a wrapping format starting from the pulmonary artery ending into the aorta, and this wraps around the heart as a single muscular sheet. And this has components of a right-sided component, you have a left-sided component, you have a descending component and ascending component. These two components form a part of the left ventricle. I am going to show you again. What is the echo correlation of these sheets of muscle across? This is the, if you see it in a short axis view, then you see these layers kind of wrapping around the left ventricle. And if you have a correlate of a left parietal long axis view, these are the two layers, ascending layer and a descending layer, what you see on the myocardium structure. Similarly, on a apical 4-chamber view, you see these two layers. And where does the hematoma settle? Hematoma settles in between these two layers of myocardial structure. Now, echocardiography features of intramyocardial dissection. How does it look like, and why do I say this is intramyocardial hematoma? Now, this is the pics we picked up from the literature, and you see this is the hematoma which is happening in the myocardium. This is the mixed echogenicity, some translucencies here. Now, this is another where there is a lot of liquefaction of the thrombus. Again, a liquefying thrombus here. Then the layers of various organization of the thrombus. This is again hematoma with the liquefaction at the other end, and this is a kind of an organized thrombi inside the intramyocardial dissecting hematoma. Now, what do we do in MRI? MRI actually is a confirmatory test to prove that this is intramyocardial dissecting hematoma, or this is a thrombus or something else, and that's usually confirmatory. But most of the times the patient is kind of not in a situation to be wheeled in an MRI to be done. Now, if we do an MRI, then all the features of MRI described below are based on the iron content of the blood in the hematoma. So now if the iron content is high, and this is how the T1 and T2 images on the myocardium MRI would look like, and you can see this is a structure which is an intramyocardial hematoma. This is how the hematomas look like on MRI. Then what is the differential diagnosis? Very critical and the most important differential diagnosis is what? Is the thrombus. The laminated thrombus is the LV apex. This is very, very important to differentiate from the thrombus, because if it is a thrombus, then the treatment strategy is different. You are going with anticoagulation, right? And in cases of hematoma, anticoagulation is going to worsen the things. So it's critically important to differentiate between the two. And how do we differentiate? Now you look at this, this is thrombus, and this thrombus overhangs. You see this rounded overhanging of the thrombus, and this is the endocardial border. Now this niche kind of thing would not happen in patients with intramyocardial dissecting hematoma. Same, you see this niche, that's the thrombus, and this kind of overhanging would happen in the thrombus, not in the hematoma. Then there are other differentiating features. One is the location. Usually the hematoma is located at the apex, as I showed you in my very first two slides and two cases. Then the borders, this is very, very important. I showed you, if you have an overhanging border, it's most likely a thrombus, not a hematoma. And then what you see is the systolic expansion. If there is a systolic expansion, or what we call an aneurysmal expansion of the part where there is that echogenic structure present, which is either hematoma or a thrombus, if there is an expansion, that most likely is intramyocardial dissecting hematoma. And the echogenicity of a mixed echogenicity in a layered format. In the layered format is most likely because the hematoma is dissecting through the layers. Thrombus generally do not form these kind of layers. The intact endocardium, in case you are able to demonstrate on an echocardiography, which is kind of an hyperfractile small layer, then it's more likely to be intramyocardial dissecting hematoma rather than a thrombus. So what is the outcome? Usually the outcome is on the second, third day the patient deteriorates and becomes hemodynamically compromised. Might require a ventilation, might require a support, circulatory support. It can lead to a serious ventricular arrhythmias, and it can progress to a pseudoaneurysm and also can produce a cardiac rupture in subsequent few days. Now, another side of the story, it can resolve spontaneously and you don't see anything after about a month or so, or it can form in a chronic format with the fibrosis happens and you see a layered kind of thing in the LV apex. Now, based on this outcome, we need to plan whether to do a surgery. Many a times in an acute setting, you might have to resort to a surgical suction of an hematoma with a very, very high intra and post-op mortality. That's something very, very important to understand. And most of the times, in case patient is kind of reasonably stabilized or can be stabilized, conservative therapy and trying to see whether the hematoma resolves of its own. Yes, I think this is a very wonderful statement by Maya, that I have learned that I still have to a lot to learn. Thank you very much for viewing this video. I hope this would create a couple of myths, and I am going to post similar kinds of videos in future maybe a good idea that if you subscribe and you are notified as and when I do it. Have a good time, have a good learning.